Hi.
Today, it is my pleasure to introduce a good friend, Dr. Peltz, who is a colon and rectal surgeon at the Mount Sinai Hospital. He is interested in all aspects of colorectal surgery with a focus on minimally invasive surgery, IBD, and complex cases. He did his med school at Robert Wood Johnson in New Jersey, and then completed general surgery residency here at the Mount Sinai Hospital, after which he left for his colorectal surgery fellowship at the Lahey Hospital and Medical Center, and then came back here as an attending. Um, and it is my pleasure to introduce him today to talk about the art of the surgical take back. Thank you so much, Mike, for coming and talking to us.
Good afternoon, everyone, and thank you for having me today and allowing me to present. Like you said, I'm Michael Plietz. I'm one of the colon and colorectal and general surgeries here at Mount Sinai Hospital, Mount Sinai West. And today I'll be presenting on the art of surgical takebacks, and I'll kind of tell you how I got to that title for this. First of all, no disclosures. Just brief bio on myself. Basically, what he said. I'm one of the assistant professor of surgery here in the Department of Surgery in the Division of Colorectal Surgery. Um, but prior to that, I was a surgery resident here from 2017 to 2022. I got to spend multiple rotations here in the surgical ICU. It was actually before we had the transplant ICU. And I got I had the benefit of being taught every day by your guys' fantastic attendings who made both teaching and the care of patients a real priority. But it was a really great experience between that and then, unfortunately my COVID time at Elmhurst. I did a lot of intensive care, which was great. And honestly, I got to work with my surgery. A lot of my fellows at the time in the SICU included, Dr. Kavi, Dr. Kushner, and I forget if Jen was a brand new attending or was still a second year fellow at the time. But I had the opportunity to interact with so many of your faculty and future faculty, and honestly, those relationships have been such a very invaluable as starting as a new attending. And I did really love crit care. Unfortunately, with crit care and surgery, it comes with you having to do trauma as well, and I did not like trauma. So I am now a colorectal surgeon. But I did manage to give you guys a pretty steady stream of patients for 5 years, and spent many a night checking on patients with you guys in the surgical ICU. And just to kind of put things in perspective, like as a you really undervalue how great your ICU care is here until you kind of spend time in other institutions and at other hospitals. In other places, there's really no or there's rare fellows. There's much less step down beds, lower acuity of patients. And we had ICUs at some of these other places, especially when talking to like a lot of my co-chiefs from my year. Such less ownership of patients, or it can kind of like vary by time of the day. And we'd get like I remember in my fellowship, I'd get calls from junior residents at all times a day who were in the ICU, just like asking for help and assistance. So, my conclusion is that I've been really spoiled here at Sinai by you guys, and I just, before starting, I just want to tell you how much I appreciate that. Because I'm not gonna lie, we don't want, in general surgery attendings, we don't necessarily want patients in the ICU, but it's always nice to know that I can sleep at night knowing who's taking care of them. But how I got to this topic today. So, as you know, I'm a colorectal surgeon, so ideally we should not have too many ICU patients. But general surgery call, however, is much much less predictable. These are my partners here, all their faces, and they all do take general surgery call here at Mount Sinai Hospital. And while they have been terrific and incredible as partners, and I can't thank them enough, they do go away quite a bit, and their patients often remain. So, so as what often happens is, with these patients, these complex patients who often will require takebacks, it's fairly routine to rely on a junior partner who is more likely to have some free time early in their career to kind of assist in the patient care. So what kind of often happens, and using Dr. Kaitov here as an example, more as in jest than anything else, but the original case will be done by Dr. Kaitov, but it requires a take back. Usually the second time I'll be, kind of asked to come and assist. Second one will, most likely be, performed by me, and then, after that, more and more takebacks. It will usually end up becoming my responsibility. And while that, I would say that like as a junior attending, I can't even tell you how great that experience actually is for what it means as far as like developing yourself and your surgical skills, and how much it has taught me in my first year or two of being an attending. I also have been a fairly frequent consult in cases with colorectal origin from the ICU, so there's been a lot of lessons I've learned from my experiences so far in this first year, and I kind of want to take us through the art of the surgical take back and what lessons kind of can be learned from it. So as kind of all you know, a take back is a return to the operating room. They can be planned or unplanned. So, a planned, which is something we often do, is an interval operation or second look. You often, when we bring a patient back with an open abdomen, clearly they, have to go back to the operating room. But they also can be unplanned. This is often after a, surgical complication or if just something, new goes wrong with the patient, as you'll see in one of my examples today. The ICU role is immense in both cases, and I can't even say I can only emphasize how communication between the ICU and the surgery is essential. And admittedly, that is a common surgery team shortcoming. I think we're a little bit infamous for that in a lot of reasons. I do think we have gotten better over time as I think the surgical personality has changed quite a bit. But when communication is like going very well between in these kind of situations between the critical care and surgery teams, it really does result in better outcomes for patients. So now I'm actually going to take you through some of the more complex and challenging take back cases that I've been involved in as an attending and some of the lessons I learned. There is some data here, but a lot I'm going to talk about is pretty anecdotal. Many of these stories admittedly have some poor final outcomes, but I do feel in every instance we did the best for our patients. There are many more simple routine take back cases that I could have presented in these, but I think each of these cases today left me with a foundation on how I'm going to kind of approach take backs for really the rest of my career. So case one, this was a 35-year-old male. He was morbidly obese with a BMI of 55. It contained perforated diverticulitis, or so I was told at the time. He had been admitted to the surgery to one of the surgical attendings over the weekend. He had apparently been doing pretty well. A lot of times we try to, conservatively manage these patients. But by hospital day 4, he was suddenly not feeling as well. He had worsening pain on hospital day 3 after a bowel movement. They had, by the time I had seen him, he had just returned back from the CT scan. I'd been called about midday. I'd seen him in like the, mid to late afternoon once he got back from the scanner. Um, what you'd see on this scan here, and I'll kind of move it around it a bit, is he had some free air above the liver, where you could see where it's tracking all the way up this way. But the big finding is down by the colon here. You see a lot of inflammation and fluid that should not be outside the colon. And this tracks actually from the sigmoid colon all the way up to the root of the mesentery, which is never great. But by the time I saw him, this guy is tacky to the 130s. He was febrile to 102. His blood pressure was still okay, but his white count was in the 20s, CRP 290. So unfortunately, when you see this, you see that, that scan, you see those vitals, like, you know where you're going next. So unfortunately, around, 8 or 9 at night, I had to take this man to the operating room. We tried to look laparoscopically, but very difficult abdomen. And, from the beginning, anesthesia was really struggling to ventilate this patient. We couldn't really, even when we tried to put the insufflation up to like our normal level, they were like, we can't tolerate it. So unfortunately I had to, do what every general surgeon kind of dreads is doing an XLAP in a patient with a BMI that high, because it's often a major struggle. So we started the XLAP. We did the big open procedure. The patient, though, however, cannot be tilted or change position because of a lot of limits in ventilation. You'll kind of see this was kind of a trend in this first case. Like they had a lot of trouble ventilating the patient on the table. So it made doing a surgery like this would usually have the patient in very steep Trendelenburg. We couldn't even move him out of a flat position. So, fortunately, with 3 different residents retracting for me, which I felt bad because usually I like the residents to be more involved in the actual surgery element of the case. We were able to drain this large abscess. There was a lot of purulence. We were able to resect that area. But, what happened is that, there were several things that were concerning. One, the distal colon looked still pretty dusky, even though it wasn't actually part of the diverticulitis process. On a very high pressors, anesthesia still was struggling to ventilate and actually requested us not to close the patient. And the ostomy was really having trouble reaching. So this is a classic situation where, we had to have done damage control surgery and bring them with an open abdomen and do an ICU admission. Patient also had pretty high peak pressures, if I remember at the time. So there was concern for possible ARDS as well at the time. So in this case, the patient, I'll start talking about, the critical care element of what you guys did and what I was kind of planning for at the same time. So you guys, I don't know how you did it, but ventilation was very quickly remedied with a change in settings. I remember coming back about an hour later, I think it was Dr. DeVivo in the SICU, and he went to me and he was like, yeah, no, everything's okay now. And after that, the ventilation was never really an issue again, but it was, he was having serious issues in the operating room that you guys resolved very quickly. You guys actively resuscitated, weaned him off pressors, his acidosis resolved, he had improved urine output. And from my standpoint, I was rounding up some additional players. So on the left is Dr. Greenstein, who's one of my partners. This was going to be one of the more difficult abdomens, and I knew that we kind of needed multiple hands on deck in order to try to even bring up this ostomy. And then closing this abdomen was going to be incredibly difficult. So I wanted, the plastic surgery team with Dr. Trina and Harmony available as well. So, but as all things do, things don't necessarily go as planned when, going to return back to the operating room. Because the plan was to return on post-op day one. And I have some data as to why exactly we want to do that, especially in these cases. We were supposed to return well within 24 hours, but, there was a couple emergencies and we got bumped. And, the next thing I was being told is that there's not really going to be any available rooms till about like 2 or 3 in the morning. Which isn't really the safest time to do this case. And I have some light bulbs here, which I'll kind of explain in a moment. But we would end up returning to the OR on post-op day two at 9 a.m. in the morning. I always remember this really well because, for me, I was like, upset at the OR at the time, being like, okay, we're not going to be able to bring this case back. I was worried about closing the patient and having the resources available. But I remember it was around sign out. I saw Dr. Kavi and Dr. DeVivo, told them that we were going to be delayed till the morning. Although they were giving us a time at 9 a.m. and they were like, oh, that's great. We'll make sure that we diurese this patient as much as possible. Like, to hopefully help you close. And I'm, going to talk about it a little bit more in a second, but that was crucial in this case because, when we did the reoperation, we actually had to do a partial colectomy. We had to resect actually most of the left side of his colon. It did, unfortunately got very, very dusty. We created this end colostomy that was very difficult to reach, but then plastic surgery was able to do their complex abdominal wall reconstruction, and would just use a wound vac for the skin due to the contaminated nature of the case. But that extra time that was used and the diuresis that was performed in that, I'm almost positive because it was kind of a close call even at the time that we did this case. If that was not done, if they had not responded in that time and done that extra care during that period of time, we would not have been able to close the patient's abdomen. It was, the amount of edema and the distension of that guy's bowel at the time of his original surgery was like immense. But it was a day and night change by the time we went back on this early part of post-op day two. And the diuresis had a huge part of this. And he actually ended up doing very well. He would come back to the ICU. He did take a couple of days to get extubated, a lot of stuff going on. But overall, he had a great recovery from that point forward. So to kind of go from the surgery view of a planned take back, almost always starts with a surgical emergency. Following that, you guys make them better. So kind of explain the magical hat and wand here. First of all, like, obviously I have no need to explain to you all how to resuscitate and stabilize a sick surgical patient. If anything, you guys would be teaching me about that. But I always find it funny because if you go through any surgical study source on our yearly exams or boards, they often kind of breeze past the ICU part on take-back cases. You'll often hear them be like, oh, the patient goes back to the SICU, and essentially like all worries are erased until the take-back happens. The things that they did are just like magically made better. So, but once that happens, once the patient's, more stabilized, we have the option of then returning back to the operating room. So for planned takebacks, for us, for our patients, these are usually septic shock, such as a perforated viscus. It can be a mesenteric ischemia case, which I'll talk about a little bit later. Trauma for many, many reasons, although you'll more see that at Elmhurst or Morningside compared to, at where I'm at Maine Hospital in West. Necrotizing infections. Vascular does this pretty often for the thrombolysis catheters, but you also see this with stage transplants, hemodynamic instability, or the pretty rare abdominal compartment syndrome, which, does happen from time to time, but when it does, it's almost always going to require a planned take back. In general, these patients are incredibly sick. The initial case is typically emergent, urgent at least. And really, these patients' condition can be evolving before our eyes, and the surgery team should be paying very close attention. I said as a resident, and often at nights, I was, very often living in the ICU, checking on patients. Like I always tell you guys, never hesitate to bother the surgery senior resident. Like these patients, they should be around checking on them every hour or two at the minimum. And if they're not, always never hesitate to make them come back. ICU care is vital in this both before and after the take back because they're often coming to the OR, going back to the surgical ICU, say with an open abdomen, and then they're going to really need that intensive care until they go back for their take back, and usually afterwards. And like I said, there may be multiple takebacks as you'll kind of see in some future cases I present today as well. So these patients have, usually have either two things. One is like, what we call like the lethal triad. This is mostly with trauma, especially with severe blood loss, where they have, coagulopathy, acidosis, hypothermia, and the cycle just goes and goes, and these patients can really spiral very quickly. And then what's kind of called like the lethal trial of a triad of abdominal sepsis, which isn't really the same thing, but these patients have this cardiovascular instability, and they can get coagulopathic, severe inflammation, and we in these cases we just have to do a damage control surgery. It's not safe to perform the entirety of the surgery. Why I was so worried in this case, and this is, a little bit of data for this presentation, is that, the time the first take back of an operation really predicts successful fascial closure, or quite often, especially in a case like this with an open abdomen, where it was, not planned at the start of the case. So failure to achieve a primary fascial closure after a damage control laparotomy is costly and carries great morbidity. And that's something that we know. And so this was a study done at 14 level 1 trauma centers during a 2-year period. They had over almost 500 patients, of which 327 of them they were able to have primary fascial closure on the first take back, which they did on average around 36 hours. And what's important to know is that every time you do an additional take back, it's only significantly harder to close the patients. We're very fortunate here that we have Dr. Tarina and Dr. Harmony who manage to close patients that I have no idea how they do it sometimes, and have a lot of like tools at their disposal. But for the most part, most places don't have that, and it can be very, very difficult to close these patients after the first time. So, but this study found that increasing time in the first take back was associated with a decreased likelihood of primary fascial closure. And each hour delay in return to the operating room after 24 hours has a little over 1% decrease in the odds of a primary fascial closure. So in this patient who at best I thought may have a 50% chance of being able to be closed on their next return to the operating room, those extra 12 hours in my head, I was like, man, this is going down to like maybe around a 30% chance of this patient being able to be closed. And based on how the bowel looked at the time, I was very pessimistic. So, but I can tell you that the amount of the diuresis and the change in management that was done is a major part of what allows us to close the patient. So my first anecdotal lesson learned today, I'm saying, is close communication between surgery and critical care teams can actually allow for modified care to improve surgical results. And I felt like this was a prime example because that diuresis was such a major portion of what allowed us to get the result we got for this patient. And he is really actually doing fantastically, and he's trying to convince me to reverse him right now. And he has fortunately lost about 100-something pounds, so he might eventually be able to do so, but I'm not looking forward to it. So here's case 2. This was early this year. I have a feeling many of you will recognize the story of this patient. The patient was here for a while. 22-year-old female, BMI of 66, many additional comorbidities. It's a sad case overall, but who had already been here multiple trips to the OR for a debridement of a necrotizing soft tissue infection of the left groin. So this is a patient who had already had many planned takebacks. She had been relatively stable for the past week or so at this point, but then suddenly on a Friday had a sudden kind of a little bit of increased pressure requirements, high fevers. She had actually been brought on Friday back to the OR because the initial concern was, oh, this must be the groin, the necrotizing infection must be spreading, but it was found to be clean. This was a Friday. I was coming on to cover from my partners on Saturday. My sign-up was kind of like, they were suspecting, probably a respiratory cause, but the patient was getting scanned. Well, as the scan will kind of be able to show here, it's very hard to see. There's a lot of, the patient was, quite large and quite edematous at this point. But there was increased diffuse dilatation and severe wall thickening of the small bowel, suggesting a worsening enteritis and ileus. And there was increased like mesenteric edema, new small bowel ascites, and they said, a component of bowel ischemia is not definitely excluded. You can see the area of here where this necrotizing infection was, but if you kind of look more back at the bowel here, like all the bowel like doesn't look great. And the more and more you look at it, like now that I know what we ended up finding, the bowel was looking, it was quite thick walled here, and it was so it was starting to look a little bit hypo enhanced as well. So I have Dr. DeVivo here again. He is a focal point of these first 2 cases. So the patient's pressure spiked. They were on max levo and vaso, and no response to the fluid resuscitation at all. And this patient, because of other renal concerns as well, had been on some CVVH, and the lactate was increasing slowly even despite that. And the patient was persistently febrile to 39 degrees Celsius. So at this point, I got a call directly from Dr. DeVivo, and my first thought to myself was like, oh, like what do I not know? Like and he called me, he told me, and straight up was like, I think this is in the abdomen. I think this patient needs to go back to the operating room. I think this patient needs to go to the operating room and get explored. And I'll be perfectly honest. You call a me or any of my surgical colleagues, and you tell us that a patient with a BMI of 66 needs like likely an XLAP. We're going to look for any other possible source it could be for this patient to go to the not have to go to the operating room for that. It's within our nature. We know what the outcomes and how poorly those cases can go. Um, and I asked him about, I think, every other part of the body. I was like, oh, you don't think it's the lungs? And he was like, no, we did a bronch, we did this, we already got imaging on this. Like her breathing is fine, her vent settings have been stable. I asked about the groin. I asked about the patient's like, if there was any urine cultures done. And I got to say, within those first few minutes of, through, brief back and forth conversation, he convinced me pretty clearly that, it was the only possible source. And with that exploration, we weren't going to be getting source control. So I would bring her to the OR for septic shock to an intra-abdominal source. So we ended up doing a diagnostic lap, XLAP, lysis of adhesions, and temporary abdominal dressing. And I'll explain why we didn't resect any bowel at this point. So this patient had non-obstructive mesenteric ischemia. The bowel looked terrible. This is a picture, a photo from the case. The bowel shouldn't look this color. You'll see a lot of it is like very purple, pink over here. There's some areas of the bowel here which look a little bit worse. But the whole bowel from the ligament of trites to the ileocecal valve looked like that. So it all looked terrible, but none of it was dead or dead yet. And you look at this and like not all of it's going to survive, but we have no idea what's going to survive, and that's always kind of the question. So we drained a lot of like pretty phallocytes, which was probably the first part as the translocation was happening, which was causing these fevers and the pressors. But we knew some bowel was not going to make it, but we just didn't know which. So we kept the patient's abdomen open, and we were planning to bring them back in 24 to 48 hours. Sometimes we wait a little bit longer in these patients. We know they're not going to be able to be reclosed at the first take back, but that allows us to delineate like alive versus dead. And what's key in these cases, and what we did in this case is that post-op, we really increased the resuscitation because in non-obstructive mesenteric ischemia, this is usually a low flow state. And and doing active aggressive resuscitation, trying to see if we can wean off pressures and all that, really allows us to salvage as much bowel as possible. This patient had a lot of comorbidity, so it was this was really done under strict guidance by the POCUS again and again. And the patient actually did improve really across the evening into the night. And we were going to go back either the next day towards the evening versus in the evening versus the next morning. Well, things never go entirely as planned. So around 2 p.m. the next day, around 20 hours post-op, the patient really started to tank. The lactate went from 2 to 8 within, the course of less than an hour. They were back on 2 pressors despite significant resuscitation. I remember being told that we actually cannot give any more fluids. So, it was another case where we had to do a cat 1 or, in case anyone doesn't know what a cat 1 means, that means we're going to return to the operating room, and the operating room has to be ready within an hour by like law. So we did a category 1 surgery, we returned to the operating room, and in the end, like from the start of when the patient started the tank, I think we were back in the operating room within 90 minutes to 2 hours, which is actually, especially in a non-trauma setting, is actually like quite exceptional. We resected about half of her small bowel. She had about 170 centimeters proximal and 30 centimeters distal, which I got to say, based on the first case, is far better than I expected. We knew bowel loss was inevitable, but we really did make the best of a pretty terrible situation due to, close communication and very quick action. And to kind of go through the unplanned take back, because usually we do a surgical case. Usually they have to go back for an urgent return to the OR. In this case, for a completely different reason, but often it's for a surgical complication. And then you guys get the chance to, magically make them look better after we do all of that. The most common etiologies here are, anastomotic leak, bowel, bio leaks, especially for cases like the Whipple or a Whipple with that, or a pancreatic duct leak, or, for many transplants as well. There's small bowel obstruction, post-op hemorrhage, severe wound infections, some severe thrombose grafts and transplants are a very common reason. And then, missed injuries where we injure an area of the bowel and there's like, stool leaking out. But there's many others as well. In these unplanned takebacks, once again, either very sick, often from a complication. It could be septic or hemorrhagic shock. A lot of times from a critical care standpoint, you guys are probably first meeting this patient, either post-op or a lot of times, as RRT, seeing these patients as they're, you know, be frank, going to shit on the floor. The take back is, urgent or usually emergent. And like I said, the surgery team should be paying very close attention. In this case, they should be next to the patient. So if they're not, you should be asking why, because this patient is going to be going to the operating room in a very, very short time span. So there should be someone in the surgery team that there at all times. ICU care is always going to be vital after these procedures, but occasionally also before. So this may at time and these cases at time may entail another planned take back, as you kind of saw in the case that is presented. So I'll be perfectly honest that, this lady was rapidly deteriorating. And in the end, at the end of her, I think it was about a 4-month hospital stay, she didn't have the best outcome. Eventually, she would pass away, but it actually wasn't from, the mesenteric ischemia of her bowel. She would eventually throw a clot that actually, killed off her duodenum and her pancreas, which, unfortunately is not survivable. But she was 22. The family wanted everything done. And, I really feel in this case, our close communication between the surgery and the critical care teams really can lead to quicker overtime and rescue the patient. And in this case, I would especially say that attending conversations were vital. And, I don't think without, the urging from Dr. DeVivo in this case that the patient would have even survived past that weekend. So for a third case, I'm going to talk, this is going to be more about, the idea of futility of care in a way, and especially how it could affect takebacks. So, there's two very different scenarios I'm talking about here and two very different decisions made. Both of them, I don't think either was the wrong decision. A lot of it's going to depend on the family and the patient and what we think is possible. This first one, 55-year-old male, no past medical history when he arrived at the hospital, which always makes it very hard. He was discovered to have amyloidosis, severe liver disease, and he had recently been admitted for elevated bilirubins. He had multiple ERCPs, stent placements. And prior to when I learned about the patient, the day before, one of my colleagues had taken him for an emergent right hemicolectomy because he was found to have an ischemic right colon and the abdomen had been left open. This was all done after an extensive family discussion. Everything had gone pretty well. The case actually had had some blood loss, but everything had been very dry at the end. And the plan was to return to the OR the next day for reevaluation and potential closure. However, like I said, with these takebacks, things don't go as planned. Things can change very, very rapidly. And on the morning of post-op day one, the Apthera, the open abdomen out dressing, the output went up to 250 cc's an hour of frank blood, which is bad. The lactate was rising, the lactate was greater than 10 within a very short period of time. The patient was maxed out on pressors. There was worsening acidosis. The INR was up to 3. Also in presumed possible DIC. They were receiving considerable blood products. Everything was being done from the ICU standpoint to make this patient even being able to just survive. So to put this into perspective of how bad this bleeding was and how quickly this was happening is the Apthera wound dressing was actually being tented up by the amount of blood that was in the abdomen. And, usually when you see this kind of situation, it's at like a trauma center. It's at a center that's there is a systematic setup for this to deal with these exact situations. So, but in a situation like what we had at Mount Sinai Hospital, that's not, our normal setup we're normally dealing with. And in the situation of this patient, there was a big critical question, which is what is the cause of the bleeding? So post-op, there was really two options. It was either that there was a post-operative bleeding vessel that was essentially causing the patient to essentially exsanguinate, that potentially could be stopped, or was this diffuse bleeding from, coagulopathy of the patient observed after surgery? They're having some blood loss and, this patient, had severe liver disease. And unfortunately, there's really no way to know. I mean, the patient could have got it, in theory, you can get a CTA, but this patient was so unstable, you're not getting this patient to the scanner. And after, this was all discussed with the family on a very urgent basis, and the family wanted everything done to save this patient. So right away, everyone's mindset has to change to, how do we form this coordination between critical care, surgery, and anesthesia for an attempt at the OR? This all has many parts. First of all, your first thought is, does this patient even have a chance of a positive outcome? And in this case, technically, if they have a post-operative bleeding vessel and you could stop it and stop the bleeding, then maybe yes. Is there anything else that can be done in the ICU before the procedure? I think this patient had gotten maximum resuscitation and they were actively getting resuscitated up to the point, with all sorts of blood products, up to the point they got to the operating room. Anesthesia had to be prepared for all resources for this case. And like for as a surgery team, we had to have all equipment and extra staff needed to expedite the surgery. This is in fact when I learned about the surgery. I was asked to come in as a second pair of hands, and basically, be ready to treat this as essentially like a trauma. Go in, pack the abdomen, do everything we would. And the key thing is this all has to be coordinated between all these teams so that it all happens in the same 30, 40-minute window so this patient actually could potentially be saved. So I'll be honest, in the surgery, there was a little bit of a mixed bag. We actually were able to ligate multiple bleeding vessels in the mesentery of the colon that were causing significant hemorrhage. However, there also was diffuse oozing in the abdomen. We stopped the blood, we stopped the bleeding vessels, we packed the abdomen to kind of help hopefully stop the diffuse bleeding, and we replaced the abdera within 30 minutes. The patient actually maintained the H&H relatively well. So all in all, like our coordination, everything we planned had gone well. And, the patient at the time we were actually we put on the dressing and we were getting ready to start ready to get leave the room. We thought to ourselves, this actually this whole situation had worked out. Unfortunately, as things do, in a patient who's this sick and has this kind of comorbidities, the patient actually would code from cardiogenic shock at the time of at the end of the procedure. We actually have a photo here of the autopsy of this person's heart. But besides having amyloidosis that was affecting the liver, they actually had it in their heart as well. This is what their heart looked like, and they had severe heart failure as a result. So the patient's body just couldn't keep up. And at some point, obviously, this patient, whether we brought him to the operating room, was going to reach this kind of level of cardiac event. But the stress of the surgery and our chance in trying to save the patient would actually code as a result. But I don't want to kind of get lost in is that the coordination made this take back possible. I was trying to look for more of a little bit of a happier ending kind of case, but I think this patient got the best possible chance to survive this surgery, and it was only done because all the teams worked so well together. And there's three critical teams during any surgical take back. This includes, and this is the surgery, anesthesia, and critical care team. And this isn't just the doctors. This is the PAs, the NPs, the nurses, the OR staff, respiratory, transport. Because if they're not all aligned in this same time period, the patient's is not going to survive. The communication is vital. The ICU, you need to optimize the patient in preparation for the OR with any means possible. Anesthesia needs to transport this patient with respiratory therapy, but they need to be ready to resuscitate the moment they go in with pressors and blood products. And for surgery, we need all the resources possible to expedite the procedure with maximal efficiency so we can get this patient, achieve results, but get them off the table. And, we did this, and, sometimes it doesn't work out, but we gave this patient his best shot. And, this patient, his surgery essentially was somewhere between 30 to 40 minutes long. So my lesson learned here was that, case coordination across specialties is vital to the potential survival of our highest risk patients. So kind of looking on the opposite end of this, and this is a little bit of a different case. Actually, technically, it's not a take back. If in anything, this is, in many ways, the decision not to take back. But every one of the teams in these scenarios have questions. It's like, first question always, can this patient be stabilized? What does that entail? When is the take back happening? Can the patient tolerate a return to the operating room? Is the patient's condition worsening? Does this patient want this? Is everyone even on the same page? But, some other critical questions come in is like, what is the angle? Like, where is this going? And, is care futile? So I'm actually now bringing up a very, very recent case. Even at the time when I originally made this presentation, this case hadn't happened. So I had edited this in very recently, but I just think it's a great example of this is a patient who ends up not having a take back. And, the art of the take back can be as much about knowing when not to do it. So this is a 50-year-old male, end-stage liver disease due to vanishing bile ducts with a MELD of 34, pulmonary hypertension, end-stage renal disease, apparently quite functional before coming into the hospital, had come in for multiple reasons, but then they developed a sudden and severe Fournier's gangrene involving the scrotum and the perineum. He was previously already intubated in the TICU and on rising pressors. And urology actually got called first. All the Fourniers that I'll kind of show on the imaging originated from the scrotal area. So they had seen the patient, had a comprehensive discussion with the family, and brought him to was had already done this like category one emergency surgery to the operating room. General surgery had been basically consulted, I guess, essentially pre-op almost on the way or versus an intra-op consult. Then I actually ended up getting secondarily consulted by one of my colleagues for like the colorectal concerns for this case. So this patient um, had a pretty extensive case of Fournier's gangrene or a necrotizing fasciitis. You'll kind of see coming down here that it kind of originates here at the bottom of the testicle and the base of the scrotum, kind of goes all the way across the perineum. And you see like it probably goes to a sacral decubus area. It's kind of hard to tell what's going on with the anal rectal area down here at this point. But we knew it was going to be a relatively bad case of a necrotizing infection. So this patient, before we even got there, first urology had come in. They had excised and debrided their area. They'd done a bilateral orchiectomy already. So both testicles had been removed. They had, basically, and they had found that like even the penile area was relatively necrotic in appearance. So next we had come in and, when you start these cases, the issue is you never really know how severe they are. So I always say there's like three types of necrotizing infections and how I kind of categorize them. There's the ones that are really like, they're not really a necrotizing infection. It's more just a bad necrotic infection where really like it's essentially a bad abscess that's kind of like locally eroding, but they tend to not get, overly sick. I actually did one of these cases just yesterday. A lot of times in our cases, they're related to perianal fistulas. But they're more low, but a lot of times they've evolved over the course of like, days to a week or so. Then there's like more necrotizing soft tissue infections, which, tend to be more superficial. They evolve pretty quickly. You need to get control of them. They can get very severe, but they tend to also be a little bit slower in their evolution. And then there's what this was, which was a true necrotizing fasciitis, an infection that based on even photos I saw of the patient's like, scrotum and stuff the day before, was really there, or if it was there at all the day, was very minimal and was rapidly evolving before our eyes. So this patient had an extensive excision and debridement of a necrotizing infection of the perineum, groin, suprapubic region, the whole perirectal space. I had to drain this big horseshoe abscess around the anus. It extended all the way up into the retroperitoneum. Like I was extending essentially my whole arm up through this space into the patient's essentially lower back, which is a very dangerous place to be, really dissecting, especially if it's going to be any kind of blind dissection. And then anteriorly, it was going up and it was going just up to peritoneal reflection. I could feel like there was the last piece of tissue. And the peritoneal reflection, if I was to break through there and this infection was to break through there, which it likely could have with a slight push, this is a patient who had liters of ascites that would have immediately come out through the opening we had created. So in this case, we had done as extensive of a debridement as we could. We had put in multiple Penrose drains. We had did a rigid sigmoidoscopy to look at the rectum and the anus. The anus wasn't looking too hot and would need to be resected, but the rectum surprisingly still alive, but was looking dusky. But essentially, this was a case where I was like, I don't know if I can ever adequately really get source control, and I don't know how far I can really take this or how far I should take this. In this case, you sometimes you just got to stop. You got to stop. You got to think. You got to talk to someone who knows better about this patient's care, knows better about their health status at baseline. So I unscrubbed from this case, briefly because this, like I said, it was incredibly extensive. My next steps were I was going to have to resect, do a distal proctectomy of the patient that I would just staple off and leave closed. I would have to keep debriding into the retroperitoneum. I'd probably enter the peritoneum at some point, which I don't know what I would have done with that ascites. But really, I had no prior knowledge of this patient besides my quick review on my chart arrival, the chart on my arrival into the OR. So I called the TICU attending, which I hope she doesn't mind, which was Dr. Wang in this case. And, it was critical because we discussed all the intraoperative findings. I told her how I felt like this was likely going to be, I felt like I was probably doing something that was futile. I needed to know more information about the patient's clinical status. And, by doing this, we talked through the entirety of how this patient's care was going. And I think that was vital in this case because we stopped, at a point where we had already done a bunch of surgery, but how much farther the surgery would have gone. And if this patient was, if this patient was, 25 without liver disease and stuff, like, maybe we take that chance. Maybe we do everything possible. But, this was a patient where, like, the survival I felt in this point was approaching essentially, was getting, right at 0%. So, it allowed us to come to it allowed us to avoid these future takebacks. And like I said, this was a case to me that told me, like, was a pivotal case of, like, when not to take back the patient, when not to plan for that to be the next future step for these patients. And, through our conversation, we had a unified message. And, this allowed for an immediate family meeting with the patient's family, to tell them, like, this is what we found. This is what the patient status was beforehand. This is what we saw in the case. And, we've done everything possible, but, like, anything further than this is futile. And we want to give you the time you have with your family. And we want to, we don't want to, I don't want to do a debridement that would essentially only, really, disfigure the patient in their final hours. So my final kind of anecdotal lesson learned here is communication between surgery and the critical care teams can really avoid futile care as well, and allow for that unified message that need for patients' loved ones. So kind of why I called this the art of the take back is, art here, not the fine arts, we're talking like kind of like a Bachelor of Arts. Art is more referring to a learned skill rather than the fine arts. And, that learned skill is, the ability to determine results with good execution, often with a given amount of time, energy, or both. And this usually requires, general versus, like, domain specific skills. And, that could be time management, teamwork, and leadership, or as opposed to, like, certain, like, specialty specific skills. And, I feel like a surgical takeback requires, like, every element of this from, like, multiple teams, specialties, and professions. And if any piece of that is missing, like, we will not get the optimal outcomes for our patients. And, and, I really feel like, I spoke of 4 lessons that I learned today, but I'm sure as each year I'll have 4 more. And as I kind of progress further and further through my career. So I think, this is the art of the surgical take back, I think, is something that requires so much adaptation on a case by case basis. And our ability to work as a team and kind of, function and really, make this an art, allows us to really get outcomes that I don't think are necessarily feasible at, many other hospital systems. So one more kind of thing before I go, just to, more give you a warning, is that basically surgeons are trying to find new ways to use takebacks in the ICU for better outcomes. So recently, actually, for diverticulitis cases, a lot of institutions in Europe have been taking emergent diverticulitis cases, just doing the resection and leaving them with an open abdomen. This has been done in cases with people who have, like, Hinchy 3 or 4 diverticulitis, which essentially means they either have purulent or feculent peritonitis. They'll get enough therapy put on, and they'll come back in, like, 48 to 72 hours, and they'll see at that time if they can do a primary anastomosis and just leave the patient undiverted. And in that case of 30 patients, it worked in about 20 of them. So it hasn't really kind of reached especially the northeast of North America yet, but it is something that's more commonly happening. So just fair warning, you may see some of this in the future. Not sure if it'll ever be from myself, but you're the care that's provided in the ICU, as it's like, as people have seen that as such a, not just a, something that we sometimes rely on in the most critical situations, but as, a tool that can be used to benefit patients in, like, in more controlled scenarios. You might see more of these patients, in the coming future. But I just wanted to say, thank you for everyone for having me today. I'm always going to be forever grateful for, like, the training you provided me as a resident, and still the care assistance you kind of give me on a, every day with my patients every day. And of course, happy to answer any questions.
Mike, thanks for a great talk. One of the best that I've heard, on the subject. And I'm glad that it was recorded, because I'd like the fellows to to all have an opportunity to see it. And um, thanks for the credit about being able to ventilate patients in the SICU. Well, I mean, in the ICU, wherever. It's something that we have to give a little credit to the ventilator as well, because the ventilators in the OR, they're designed a little bit more for short-term use, and often they can't maintain a high flow rate and a high inspiratory flow rate at higher airway pressures. It tends to kind of drop out. So sometimes an ICU ventilator could be used perhaps in the OR anticipating a very difficult case. But
Yeah, it was. I don't think any of us expected this at the time. The patient was, he was very, very large. He's actually down to a BMI of like, I think it's like 35 now. He's lost a significant amount of weight. But he was a very, very big guy, and from the very start of the case, they couldn't ventilate him. So, the correction that happened in his ventilation from you guys, by the time we brought him back to the OR, and he went back to an OR ventilation the second time, and the correction in the ventilation that you guys had performed allow us to do it, be able to bring it back to the second time without any issues. So I can't thank you enough.
well, thank you.
All right. Once again, thank you guys for having me today, and I appreciate the opportunity to present.
Thank you for your time.